evening, everyone. I'm Shweta Mishra, and I welcome you all to this session on birth control pills and PCOS treatment in association with the PCOS Tracker app that aims to help women keep track of their PCOS symptoms. More information about which is available on their website, pcostracker.app. Today, I am beyond excited to welcome our eminent guest expert, Dr. Carolyn Alexander of Southern California Reproductive Center, to educate us about the risks, benefits, and everything we want to know about the use of oral contraceptive pills in the management of PCOS. Winner of numerous awards in medicine and teaching and featured in several media outlets, Dr. Alexander is board certified in obstetrics and gynecology, as well as in reproductive endocrinology and infertility. She has done extensive research on PCOS and specializes in dealing with patients facing infertility as a result of PCOS. Dr. Alexander, welcome to the show. Thank you for finding time to talk to us today.
Thank you so much for having me. It's an exciting topic, important topic.
On the patient panel, we have PCOS advocates Lisa Rosenthal, who has been advocating for 30 years in this field now, and Tatiana Alafuso, who is a PCOS warrior and PCOS researcher joining us from the UK. Lisa, Tatiana, welcome to the show, and thank you for joining the panel today.
Thank you for having us.
So Dr. Alexander, I know you want to get back to your patients as soon as possible, so I'll just jump right in. And to set the stage and give a little bit of background to our audience, could you please begin with talking a bit about the mechanism by which birth control pills help in preventing conception?
Sure. Oral contraceptive pills are a combination of estrogen with progesterone. The progesterone is majority of the mechanism of action, but there is a little bit of estrogen in there, which helps keep the uterine lining stable so that people don't get spotting when they're in between placebo weeks. The interesting thing about what that does is it tells your pituitary, which is your master control gland, that there's, oh my goodness, there's plenty of estrogen here. Please don't send follicle stimulating hormone down to stimulate a follicle and ovulate. In addition, it also tells LH, which causes the egg to come out of the shell when you ovulate, to be suppressed. So typically, most people on the birth control pill, if you're taking it every day at the same time, will have suppression of those two master hormones, and it increases your liver production of SHBG, or sex hormone binding globulin, which then can bind to the free testosterone, which is floating around. So a lot of people with acne or hair growth or hair loss on their head can start to see some improvement with that. Because of the rise in SHBG, it drops the free testosterone. In addition, it blocks the corpus luteum, or the ovulatory remnant that makes hormones. And so people tend to have less chance to get pregnant, and it thickens up the mucus at your cervix so that sperm can't really swim as freely through. But if we skip a birth control pill, there is a chance to spontaneously ovulate, and some patients can get accidentally pregnant if they're not consistently taking their pill at the same time, especially if they weigh over 200 pounds. There's quicker absorption in your system and an opportunity sometimes to spontaneously ovulate.
Right. Okay. Thank you so much for explaining it so clearly. And how do these pills help in PCOS treatment? Could you elaborate what mechanism is at play there?
Sure. It's similar to the increase in SHBG, or sex hormone binding globulin. That will help us bind the free testosterone. There's a little debate about whether DHEAS, which is a male hormone from your adrenal gland, if that will slightly be suppressed. I've had patients over the years ask me to check that when they're on the pill, and we still do see it pretty high. The way that the birth control pill helps PCOS is to protect the uterus from endometrial hyperplasia, which is a pre-cancer issue that comes when the lining thickens because we're not getting our period every month to shed the lining. The uterine lining can get very unhealthy inside. And so it's really important, if you're not getting your period by the 40th day, to talk to your doctor about either plain progesterone or a birth control pill combo, which is estrogen with progesterone. The other thing with PCOS that I found is some people, if they feel their mood swings go up and down, there's a group of PCOS patients that when they go on the birth control pill, it's a steady state of a hormone complement and they feel a little better in their mood. But there's a subset that then also sometimes feel the blues and feel down and don't feel like themselves. Then right away, I switch that type of pill. We're blessed here to have so many types of progesterone types in the pills. Even myself, I felt different on different types of combination pills. And I can say that I can recollect the one that I felt like totally good on it and when I was younger. And so it really can affect mood in a good way and a not a good way. And women with PCOS, it does make their metabolism get better. And some patients, they feel very bloated and kind of water retention with the pill. So we change the brand for that. Let's change the type of progesterone. So usually we can kind of tailor and figure out which pill is going to help the most.
Thank you, doctor. With that, I'll move on to the patient panel now. And first up on the panel, we have Lisa Rosenthal, who has been advocating in the field of fertility for 30 years now. And motivated by her personal journey, she is determined to help others who are undergoing fertility treatment. She's the founder and teacher of Fertile Yoga program and is also a certified grief recovery specialist. Lisa, thank you for joining today, and the floor is all yours.
Thank you for having me and for being here with you. And I also have PCOS myself, so there's a lot of personal at stake. So, Dr. Alexander, if birth control pills are controlling the symptoms of PCOS, right, and they're working well, how can somebody try to get pregnant without kind of resuming those symptoms?
That's a good question. Sometimes when people say in about 6 months, I want to try, what we'll do is we'll discuss proper nutrition, prenatal vitamins, strategies to avoid insulin, yo-yoing of insulin. And right when they stop the pill, I usually have them start to try, because there's a blessing of 3 months that decrease in testosterone, as well as the AMH, if it's really high, sometimes after the birth control pill, it'll be a little lower, so less inflammation in the system. And there's sort of a blessed time where people can get pregnant. Even for myself, when I stopped the pill, I started trying and I conceived. But there are some in the past, we used to say, yeah, take a month breather off the pill, then start to try. But it seems to me that there's a lot of patients who conceive in that window of that 3 months where you're in a better opportunity. If the patient's on spironolactone, I usually have them stop at 6 weeks ahead, because it blocks the androgen receptor, and we don't want that right before the person's going to get pregnant, even though the half-life is debatable on it. But I usually have them stop at a month or more before they start to stop the pill and start to try. I warn patients that they may have to be a little more cognizant of eating and exercising and mindfulness to kind of keep their cortisol down, so that they don't get, all the explosive symptoms. Some patients get a little bit of acne that when they stop, but it takes a little time for that to pop up from stopping the pill. And a lot of people who are over 35 years old are coming in saying, I may stop the pill in 6 months. Please help me figure out what to do. So we check a semen analysis. We check if we need to check their fallopian tubes. We talk about making sure thyroid and vitamin D levels are healthy, their pap smear's up to date. So there's a few checkpoints before we stop the pill that we can do, so that you're not taking too much time off the pill and then realized that we should have been working hard on the sperm. When Dr. LeGros from UPenn did, not Penn, I'm sorry, Hershey, Pennsylvania, he did a study looking at women with PCOS, and what was interesting is a third of the time there was a male factor. And so even though in our mind we're like, oh man, it's going to be maybe hard to get her to ovulate, we got to get her as healthy as possible, we don't want to forget that about a third of the time it can be a male factor too.
Really fascinating answer. I had no idea about that sort of, lovely 3-month period. That's amazing. Really helpful. Thank you. So the second question is sort of twofold. Did birth controls stop or help me ovulate? And if so, what were they doing and why did I experience bleeding? I think the question sort of goes to the idea of, was I, the patient got regular periods, but were they ovulating? Just because you bled? I'll let you handle it.
That's a good question. So the uterus, I think of it when I teach medical students as bricks with mortar. So there's like kind of a glue between the bricks. And so for your body to shed the lining, you just need a withdrawal of progesterone and a little withdrawal of estrogen. So even at 50 years old, if let's say I'm not getting my period at all and I went into menopause, if I give you a little bit of estrogen and progesterone for even 2 weeks and stop it suddenly, you'll shed the lining. So even though it seems like it's a period and they're ovulating, it's not ovulatory periods with the birth control pill. It's because those bricks and mortar are there, and then the mortar comes away and the bricks shed. I don't know if that's a good explanation, but that's the way I think about it. And then you're not necessarily ovulating. There are some people who can ovulate on a progesterone only pill. And so that's why that pill has to be taken sharply within exact 24 hours. Because if you even go a few hours later, your body can spontaneously ovulate.
So if I'm understanding you correctly, and that was a great analogy, I love the visual. If I'm understanding you correctly, what you're saying is that ovulation and bleeding actually don't have that much to do with each other. Okay, excellent. Excellent. I think a lot of women assume that if they're bleeding, that they are also ovulating. I think that was what that question was trying to get to. So the next one you've really answered, which is how long do I need to be off birth control before I start fertility treatment?
Yeah, we use birth control pills to optimize the hormones prior to fertility treatments. So, there's a little debate on that when you're freezing your eggs, if you're thinking to freeze your eggs, that some people may respond better to the injectable IVF medications if they've been off the pill for a few weeks. But there are some people that are better coming right off the pill. It depends on your AMH and your ultrasound. But in general, if you're going to try like naturally, I would start trying when you stop the pill.
I love that. It's so individualized. So what about diagnostic testing for fertility? If a patient is on birth control, will the birth control pills and hormones, will they mask the PCOS? Will they mask any other fertility problems?
That's a good question. So it's very hard to tease out congenital adrenal hyperplasia from PCOS when someone's on the pill, because the test differential is an adrenal gland hormone called 17-hydroxyprogesterone, and that's normal when you're on the pill. And so to really get a sense on what's going on, especially in LA with our Ashkenazi population, our Mediterranean patients, they sometimes are told you have PCOS, but then when we see them and we check, we catch pretty often a non-classical adrenal hyperplasia, which can look exactly like PCOS, but it's very important to differentiate that, because if her partner has a CAH gene, then a baby has a 1 in 4 chance to get both copies, and that can be pretty dramatic and affect that baby. And so it's important to differentiate some hormones. So sometimes we do have to say, stop the pill, come back in 5 to 6 weeks, and then we'll do a panel. But interestingly, when you're on birth control pill, the textbook answer is that the anti-Müllerian hormone level, AMH, is still predictable and helpful. And that in the Europeans are using AMH to diagnose PCOS. And at ASRM, which I'll bring up at the end, they had a really interesting paper showing that if the AMH was over 6, you had a high probability that you might have PCOS. Here, we don't use it as our diagnostic criteria. We use it as a red flag to see that there might be PCOS, but we don't use it as a diagnostic criteria.
Does it affect FSH? Does
Yes,
being on the pill affect FSH?
Yes, it'll make it normal.
Interesting. Okay, so that's certainly a big thing. Thank you. Great answer. Really so helpful. So my last question is, what could or should I be on instead of birth control for PCOS? So for a patient who has to go off of birth control to try to get pregnant and has those reemergence of some of those symptoms, what could they do instead or be on instead?
Metformin will lower testosterone. Some people get GI upset with metformin. I've become more of a fan of myo-inositol, and I've even tried it myself. I think it's interesting. It helps improve insulin resistance too. And you could take that till you get a positive pregnancy test. And then the other things that exercise, diet, acupuncture. I'm a big fan of mindfulness and acupuncture too.
Excellent. Well, thank you so much. That's it for me. I'll send it back to you, Shweta.
Yep. Thank you. Thanks, Lisa. Great questions. Next up on the panel, we have Tatiana Alafuso. Tatiana, who is a PCOS warrior, passionate about empowering women with PCOS take control of their symptoms. She is a registered associate nutritionist with the Association of Nutrition in the UK and is currently working on her PhD focusing on complementary and alternative therapies for PCOS management. Tatiana, please go ahead.
Hi, Dr. Alexandra. Thank you so much for taking the time to answer my questions. So I just was curious, what are the most common side effects that women with PCOS on birth control experience or come to you about? And do these differ from those who do not have PCOS?
That's a really good question. I was, thinking about that a lot. And I feel that the mood changes on the pill seem more noticeable in women with PCOS. That I feel like I've heard a lot over the years. I do think a lot of patients with cystic acne or acne on their back see an improvement with the pill, but there's this subset of some patients, if their adrenal androgens are high, that doesn't improve, or sometimes it worsens for a short amount of time. The weight changes are it's really hit or miss. I notice in puberty, in the younger women, there are some people that seem that their weight improves when the testosterone goes down with the pill. And I think, again, because I think of the birth control pill as having 8 types of progesterone types, and some people are just so much more sensitive to norethindrone versus levonorgestrel versus drospirenone versus desogestrel, norgestimate. So I think of it as I have to sort of figure out which one's better for them, from the bloating, headache, nausea, weight gain. If the patients take the pill at night, they have less nausea to me. A lot of patients say that. They also don't forget, because everyone brushes their teeth, hopefully. So I tell them, put it with your toothbrush. So if you're going to brush your teeth, take your pill at night. And then the heaven forbid, the blood clotting risk, which I was reading articles last night to prepare for today, and I was interested to see that there is sort of an association in some women with PCOS that there's a higher predisposition for blood clots, but it's hard to tease out, is that a weight thing, like because of apple-shaped body and maybe having more of our tummy weight, which I have too, but or is it actually what's called plasminogen activator at PAI1, that the levels were maybe different in someone with PCOS. I started adding PAI1 mutation to my patients who have recurrent pregnancy loss with PCOS, and I've caught it like a few times, and it's not a common thing to catch. So there are some blood clotting things. So drospirenone, which is in Yaz and Yasmin, may have a higher risk of blood clots. So it's important to think about that. Again, it's an individual care situation to each patient.
No, thank you so much. Because my next question was actually going to be many times, those with PCOS are prescribed low dose or an ultra low dose pill like Yaz or Yasmin, including myself. And, it just, as you said about the potential blood clotting factor. So would any family history of a stroke or any kind of cardiac issues come into that when you're sort of making that decision of whether or not to prescribe a pill like that?
Yes, I think what I've been doing, which is a teeny bit of overkill, is if they say their dad or mom or sister or cousin or anybody had a blood clot at a younger age, then we can do what's called a thrombophilia panel, which is like a blood panel of genetic mutations that cause us to be predisposed to blood clots. Yasmin, to start them. But if they come in and they say, well, I was on it for years and I felt great, then I noticed that once they've been on it for at least 6 months and heaven forbid didn't really get a blood clot, then the likelihood that that would happen is low. It's the same risk is if you're going on a long flight or a long car ride, take an aspirin, a baby aspirin maybe, or talk to your doctor and think about that and keep your calves moving. Don't just be dehydrated and sitting in place for hours and hours. Anybody on the pill could get a blood clot from that.
Thank you so much.
COVID has also added a complex factor because women who've had COVID, to me, I've noticed that their anti-cardiolipin antibodies, which increase the risk of blood clots, are very high, especially if they had, even if they had asymptomatic COVID. So I think we're seeing something interesting about post-COVID patients that we're noticing that too.
My goodness, I didn't even think of that. That's so crazy. It's like a whole nother layer to even add on to the whole blood clot situation, or something to think about when you're when you have PCOS. What composition of birth control pills have you found to be the most effective for your patients with PCOS? Which they've found both tolerable and safe, or they've kind of maybe not had as many mood issues on, or things that you had mentioned before, please.
Desogestrel has been really good. I've noticed even though some of the progesterones say androgenic, and patients call and say, oh, what about that? Any type of pill will still improve PCOS patients. So low estrogen can be helpful, and also orthocycline and Desogen, all the types of pills. I have a lot of patients who love NuvaRing because they can leave it in for 4 weeks, then take it out, put a new one, and they can pick when they want to have their period.
Oh, wow. Do you mind please explaining the pros and the cons of a progestin-only pill?
Sure. If some people cannot tolerate the estrogen effect of the pill, a patient today, she said that when she was in college, she got severely depressed when she was on the pill and she didn't feel like herself. She tried different types. She couldn't tolerate it. Another patient of mine really had bad headaches and nausea. If someone has migraine with aura, they should consider a progesterone only pill because the aura has some risk factors also for blood clots. If their blood pressure is high in our young PCOS patients, we notice the lower number, the diastolic blood pressure is higher. In a lot of them, it's not always the top number. And so
That's
they
interesting.
from a progesterone only pill. And breastfeeding, we encourage a progesterone only pill so we don't suppress milk production in that window after having the baby.
Oh my goodness, thank you so much. I didn't know all of these things. And lastly, do you have any advice for a PCOS patient who has been on birth control for a very long time, and now is looking to come off of it after many years, please?
Sure. I would check a hemoglobin A1C to see if you need to be on metformin. I would plan ahead. So try to eat really healthy, lots of vegetables in your diet, exercise, and then keep a little log when you stop the pill if you're really starting to notice fluctuations in acne, hair growth, hair loss, things like that. Keep a log, and then you could discuss it with your doctor what would be the best kind of course of action to help each of the symptoms.
Dr. Alexander, thank you so much for answering all my questions. I really appreciate it.
Good to
Thank,
see you. Yeah.
Thank you. Thank you, Tatiana. Great questions. So, Doctor, I'll be mindful of your time. I have just a couple of questions before we wrap up this show. And I think you talked a little bit about this thing that I'm going to ask you. Just wanted to understand if you have observed any differences in the ease with which your patients conceive between the ones who were on birth control pills compared to the ones who were off the pill before they came to begin fertility treatments with you.
That's a good question. I think it has a lot to do with how high their testosterone is, the total and free testosterone, as well as AMH. If they come in and they've had regular periods and have not been on the birth control pill, and their androgen panel's normal, hemoglobin A1C looks good, and their AMH is between 2 to 8, I feel like it's doable. I think the patients who come in and say, I haven't had a period in 6 months, I don't feel like myself, there's something off, something's wrong, can't sleep very well, I'm, not feeling like myself. That's where I find it where it's a little more difficult. Plus, the uterus has been bombarded by unopposed estrogen because they haven't ovulated and had a shedding of the lining. So sometimes that uterus needs a kickstart with some progesterone to really like start fresh so that we don't have an increased risk of miscarriage. We want to optimize. That was a lecture I gave a few weeks ago on optimization of hemoglobin A1C before pregnancy and less congenital anomalies in the babies. Because if your hemoglobin A1C is above 5.7, you start to have an increased risk of anomalies in pregnancies, which are malformations when the early embryo is forming. And so it's really important before you start to try to get a checkup, check that your vitamin D levels 30 to 50, your TSH is normal, your thyroid level, and that your liver and kidney function is normal. A lot of women with PCOS get NASH, which is non-alcoholic, like liver enzyme bumps. And now my new question with a lot of patients is, do you snore? Because there are some people with sleep apnea, and that lowers oxygenation to the pregnancy and can cause IUGR or intrauterine growth deficiency. And so it's important to check on the whole person. And now since COVID, a lot of people don't go to the doctor as much. So we are their sort of primary care doctor as well as OB and all that.
Right. Thank you for that explanation. And lastly, I think I'll just take a couple more minutes. If you could briefly share some of the interesting research updates from ASRM 2021, right? You just visited the conference, and it would be great if you could discuss a little bit about, the research papers that are discussed about PCOS and the use of birth control pills in treatment.
Yeah, well, there was a lot of talk about AMH. There was a well-done poster on using it as a diagnostic criteria. I think what was really an echoed thing through the lectures was with IVF and PCOS is to freeze the embryos and put them in later because they had less OB complications or pregnancy complications. Sorry. If they froze the embryos. Here, we mostly do frozen embryo transfers, but some patients want a fresh transfer. we don't do it if their estrogen goes over 2,800. So if your estrogen's very high at the time of the retrieval, the uterus isn't as fresh and ready for the embryo. So it may be better to freeze the embryos for the future. The other thing they talked a bit about was the protocols for PCOS patients and ways to avoid hyperstimulation using cabergoline and metformin. And a Lupron-only trigger, which is a GnRH agonist trigger, which has essentially made hyperstimulation syndrome really very rare. I haven't, knock on wood, had one in a long time. So we used to see it so much more frequently over these 20 years of doing this, but now it's been so rare to see hyperstimulation.
Right. Thank you. That's very interesting to hear. And I'm particularly interested in the frozen versus fresh embryo transfer research that you just discussed. And would be great if we can, in another talk, we can totally discuss that, right?
Yeah.
That's it. All right. Thank you so much for your time, Dr. Alexander. I think that's a wrap for today. And it was wonderful listening to all the information shared by you. And I'm sure this talk will be helpful for women of all ages who are either, planning to use birth control pills for PCOS treatment, or they are using right now. So thank you very much for all the information shared. And thank you for finding time from your busy schedule to educate us today. Tatiana and Lisa, thanks for joining the panel today and guide us with your, very relevant questions. I thank you all for, whatever you do for the PCOS community. And I request everyone in the audience to check out the PCOS Tracker app that has been now downloaded more than 31,000 times. I would appreciate each and every feedback from you guys and help us make the app better for women to use. Please send your feedbacks to shweta@trialex.com. And to listen to our other upcoming talks on PCOS and other topics, please visit our website, qtalks.com. So until next time, thank you everyone and have a great day and stay safe.